Well, hi, everyone. I'm Daniel Williams, Senior Editor at MGMA and host of the MGMA Podcast Network. Today, we have another episode of Mindful Medicine. And this is a show where we explore the intersection of healthcare, mindfulness, and compassionate care. Today, I'm happy to note that we are joined by Dr. Andrea Sankar. Andrea is a medical anthropologist and the co-author of the newly released third edition of Dying at Home, a family guide for caregiving. And we're going to be touching on this book. We're going to discuss what brought Dr. Sankar to writing the book in the first place, but also looking at it through the lens of providers and medical practices and how they can help families at this great time of need. Dr. Sankar, thanks for joining us.
Well, thank you for having me, Daniel.
All right. Well, I do want to start with just a little bit about your background. What would you like to share about maybe some career highlights, and then share with us what got you interested and focused on end-of-life care in the first place?
Well, I came at this question from a sort of circuitous route. My doctoral training was in Chinese studies, and I did my dissertation research living in a Buddhist nunnery in southern China. I was interested in studying an anti-marriage movement, but what I ended up looking at was how a group of older women who had no children and no families, how they cared for each other in old age. So I became really interested in old age care and how that happened in the community. And then I did my postdoc research at University of California, San Francisco, and I happened to be there when the AIDS epidemic broke out. And at that time, I was part of the case-controlled study that initially identified where the virus was coming from. But my part in that was to look at how people were being cared for in the community, especially at a time of such incredibly stigmatizing disease where nobody wanted to care for the people who were dying of AIDS. So I moved more and more into community-based care and how families cope and how individual caregivers cope with AIDS. And then my own mother got sick and was dying. And my sisters and I took care of her at my home. We were all young professional women. We all had young children, and it was very, very difficult to do. And so my sisters, at their urging, they said, with your background in medical anthropology and the research you're doing on care, you should do a study on this and write this book. And so that's when I began to do the research. It involved doing in-depth case studies of many caregivers around the country, taking their stories, analyzing their stories, and coming out with this book that is now in its third edition.
That is wonderful. So just to go behind the curtain here a little bit, this is a topic that I'm very interested in as well. I get pitched a lot of people to come be a guest on the show, but when I saw this particular topic, it definitely piqued my interest. I reached out to your communications people. Going back almost 10 years now, I did volunteer for about 2 years at a hospice care facility, an organization here in the Denver area. My background is as a journalist, and so where I said I thought I could help was to sit with patients and basically, where they're able to communicate, tell their story, and then write that up and then share it with families so they would have a lasting bit of information, some of those great family stories that would live beyond the person there. And so when I saw that you had written this book, I really wanted to reach out to you, connect with you. So thank you for the work that you're doing in this field. I wanted to touch on the book itself because it is the third edition. So if you could give us sort of the genesis of the book and then what you're doing with each iteration and each new edition of the book, what would we know differently in this edition that might not be in the others?
Well, things have changed a lot since the first edition. The people who are dying have changed in the sense that in the United States, fortunately, because of our excellent health system, people live longer and they live into advanced old age. And that means that when they're dying, they're very frail. So not only do they have the disease or condition they're dying from, but they're also physically very frail, as are their caregivers often. So that's changed. continually there are advances in medical technology and in pharmacology, which make it possible to have someone die at home, even though they may require very sophisticated levels of care. That care can now be administered in the home. And then finally, with the TEFRA Act, the Tax Equity and Fiscal Responsibility in the early 80s, now Medicare and Medicaid cover, or Medicare first and then later Medicaid cover hospice care. And that didn't used to be the case. So now when the work you were doing as a volunteer, now often that, not particularly what you did, but there are more and more coverage for hospice care. So for example, now you get a physician will administer the care, supervise it. You get a hospice nurse who will be on call and is available probably for 1 week, 1 day a week visit. And then you get aides, and the aides are available maybe a few hours a day, 3 or 4 days a week. So that makes a huge difference. So the availability of care is much more expansive than it used to be.
There's so much to unpack here, and I want to be respectful of your time, but also really touch on this topic. So we have seen this. You spoke to this, that home care is better than it's ever been, or you'd have to go back maybe 100 years when doctors used to make those house calls. So, medical practices are set up to provide remote patient monitoring, other facets of home care. But you spoke to something that is really vital in this whole topic area of home care, that the burden can be placed on family members. As you mentioned, sometimes they're aging or they're frail as well. Even if they're not, I've talked to many people who move into a situation where they care for a family member who might be suffering from dementia or other long-term issues, and the burden it causes to them, whether it's physical, whether it's emotional or mental. Before we get deeper into this, I hope you would just speak to that aspect of it and maybe what are some best practices so it doesn't burn out or endanger that family member who's taking care of the ill patient.
Well, excuse me, you've hit on one of the biggest issues in this whole process. I mean, essentially what's happened is there's been a shifting of both cost and responsibility for care from the hospital, because we recognize that a lot of people aren't going to survive their treatment, to the home and to the family, right, which means the family is assuming a lot of care. And most people are not trained to do this. Right. So it's a huge responsibility. It often, even though it's reimbursed, there are still a lot of expenses, lost work, additional care that's almost always needed that the family assumes. And the stress on the caregiver is huge. Research in the United Kingdom and in Scandinavia has shown that caregivers for people who are dying, who don't have what they consider to be enough support, have often many years of stress-related illnesses, as well as physical illnesses, literally from having to transfer the dying person. So the impact on the family-based caregiver is very large, and is something that is definitely better in terms of the kind of reimbursement that's available, but is still not adequate.
Okay. Thank you for sharing that. So in your book, you do discuss the increasing trend of home deaths. As those patients, many are saying, hey, I want to be at home. I want to be around my family. I want to be around the things that are familiar to me, as opposed to going into a hospice care situation that's outside of the home. So with this trend growing, how can medical practices coordinate, collaborate, and provide any support for those family members and for that patient?
The more medical practitioners actually understand about what's involved in this care, the better it will be. In the initial study that we did, there were 3 physicians who were not the main caregivers, but they were family members, right? They had actually never seen someone die. Many clinicians really don't know what's involved in this. And even people in hospice, people who are obviously hospice nurses and social workers, they're out in the home, they know what's involved. But for your regular general practitioner or even an oncologist, they may not know how much strain this puts on a family member. So the more that clinicians can familiarize themselves as to what the caregiver is expected to do, the better. Because the caregiver is in a situation where they're having to make a lot of little decisions. And for a trained professional, these may not seem consequential, but if you've never done this before and you realize that somebody, and you know they're going to die, but you don't want them to die at the moment for something you do, it's a huge responsibility. And sort of helping the caregiver give them more information, anticipate the kind of anxiety that they may have, be available to them for communication. All those kinds of things will make a huge difference in the ability for the families to care. And then finally, I think that healthcare providers can create a list or a resource so that family caregivers see what else is available to support them. Because it's very unusual if the hospice benefit, as it's written in Medicare and Medicaid, is actually sufficient. Families almost always either need informal support, caregivers, other family members who come in, or they have to purchase that support. Many people can't purchase that, so they need volunteer, to know about the volunteer resources in the community. They don't have time to get on the phone and find out like which church might come and sit with somebody so they can get a few hours of sleep. Medical professionals who can provide like just a list or a website where locally where you can, if you're the caregiver and you need to get an extra hospital bed, where you can get that would be a huge resource and a huge help.
Okay. So I mentioned that I did do the volunteer work when we there was a group of us and we went through a training. It was several weeks before we ever sat with a patient. In addition, we watched the documentary Being Mortal, Atul Gawande's. It was a book and then a documentary film, and then we discussed it. And I wanted to follow up then, as from a provider perspective, is there some training, or how do you coordinate or communicate with any providers or medical practices so they're doing what you were just talking about? They are in tune with what's going on at that time of death or leading up to that time of death.
Well, first of all, I would like to commend the people who trained you. That's really excellent. Yeah. And that doesn't always happen. There's not, as you know, in the United States, there's not a centralized system of medical care. So it's really up to the individual provider or community that decides to provide the kind of training you're talking about, which sounds excellent. It's really going to be on the provider's shoulders to find those resources and make them available to their staff and to volunteers such as yourself. There is no one place, unfortunately, you can go and get that information, but it's available, as you pointed out, it's available and can really be incredibly helpful, not just for volunteers like yourself, but actually for the caregivers, the family caregiver. The more they know before they assume this responsibility, it's going to be hard no matter what, but the better able they will be to cope with it.
Okay. We talked earlier about the emotional and physical toll that it can take on those family members, or it might be friends. It might be a network. They might be trading off. I know there have been groups that I was in relation with where they were a group of widows and they were caring for one of their friends, so they were trading off. So as we said, this does cause that emotional and physical toll. Are there some things additionally that medical practices or providers can do to help take some of that stress of emotional and physical pain away?
One of the most challenging aspects of providing this kind of care is the potential for stress within the caregiving community or family. If there are problems, say, among siblings when they're growing up and they have to care for an elderly parent, those problems are likely to come to the fore. And so I think providers who are aware that a family may seem like they're okay with this, but they should be always alert to the fact that it may not actually be the case, and to push a little bit harder to find out, okay, who's really going to be there? You've got one person living in, like, I don't know, Minneapolis, and that's where the elderly mother is. Now, are the other people really going to come in? They say they are, but are they really going to do that? Because not only do people not show up, but people have real strong arguments about what kind of care should be provided, how much, at what point do you, like the like giving antibiotics. Siblings will have a huge fight. No, they said they wanted to die. Well, we want to keep them comfortable. So caregivers need to be alert to the fact that this can cause massive stress within the family or caregiving network, and to help anticipate that. And then hospice social workers are outstanding in helping to resolve these. They can't solve it, but they can create a situation so people can talk to each other. So that's a real issue that they can get ahead of a little bit. They can't solve it, but at least they can anticipate it's likely to happen.
Yeah, that's what I wanted to ask you about next was how do you coordinate that communication and collaboration where everybody's on the same page? Do you have some best practices to share with people about that?
Well, there's a whole range of things to do. I think the most basic is the actual hands-on care for the dying person. In that situation, as I said before, the person who's the main caregiver typically is not going to have ever done anything like this before and really won't know what to do. So having them keep a notebook every day of the symptoms, particular care, particular care problems, and the medical providers can say, this is what we need to know. Maybe even give them a little notebook and say, you can write everything down in here. We'll read what you have to say. So that, and then be on call for the caregiver. If the caregiver has a real question about, like, what do I do? I see somebody's doing such and such a thing. Just knowing that there's backup, and then on the caregiver's side, on the medical professional side, they can see a record designed as best as they can give, guidance to, that then they can use to help the family support care. And then, as I said before, understanding how stressful this is, and that most families will not have the resources to really provide an adequate system of care. And then they can say, looks like so-and-so really needs to have a good night's sleep. Why don't you call such and such a place? Typically, hospice does not provide 24-hour care during the night, but maybe a medical practice will know where there are volunteers, like you yourself can come and sit with the dying person so the caregiver can get a rest. So helping to direct them to this extra support, but also anticipating just how difficult it's going to be, and that the caregiver needs to have a mini, like you said, a kind of a training so they know what to tell the doctor, and then the doctor can help to interpret what this means when the person gets in touch with them.
Yeah. Going back to that training, we spent an entire session strictly looking at the legal issues, the legal ramifications, because that is very important there. You don't want to get sued. You're there to help, but you don't want to cause any issues. As far as medical practices are concerned, what should they be as far as in advising families on advance directives and other legal preparations? How can they help provide any guidance, but also not get into any hot water as from a legal perspective?
First of all, the physician should probably realize that most people have no idea what advance directives are, and they think it means like pulling the plug. That's what everyone.
That's what people talk about. Yeah.
Yeah, I know. And so they need to help them the family understand that, and the dying person. Ideally, the dying person should be part of this. That there's a whole range of very subtle decisions that have to be made, such as we said before, antibiotics. So say someone develops a urinary tract infection. Do you treat them with antibiotics to make them more comfortable? But it could potentially extend their life. And if they're not supposed to get any invasive treatment, how does the dying person feel about that? How do you feel about that? Those are the kinds of things that can be spelled out to the best of their ability in advance directives. They're not perfect, but they will give guidance to the people who make the decisions if the dying person is not able to make those decisions anymore. And that kind of advance directives will help resolve some of the family struggles that happen. If you can say, okay, grandma wanted us to do X, and so even if some of the cousins don't agree that grandma should have X, you can point to this document and say, yeah, but this is what grandma wants. So it will help the family resolve their own in their decision-making process, as well as sort of help provide the kind of care that the dying person had wanted to have.
Okay. One of the more interesting aspects that I saw in your book that it says that in light of the COVID-19 pandemic, there have been significant changes in how end-of-life care is approached. I'm so interested in hearing more about that from your perspective and how medical practices can play a role in that as well.
Well, unfortunately, I think medical practices need to anticipate that this is going to happen again. If it's not COVID, there's going to be some other infectious disease, likely a pandemic. Everything you read from the World Health Organization, the CDC says this is going to happen. So medical practices need to anticipate that they may have to deliver care somewhat remotely. There's a case study in our book of a woman who left her job and came to care for her mother. She assumed this responsibility because she was coming to a community where she had several aunts and uncles, lots of cousins. She expected that she would have a lot of care. And then COVID hit. Not only would nobody in her family come into the home to care, but the hospice nurses wouldn't. She had no help at all. The hospice nurses would stand at the door and talk to her, leave supplies, but nobody would come in. And it was, she still is, several years later, she's still recovering from that experience. So this is going to happen again. So, people need to problem solve around like, okay, if they need, a patient needs to have a catheter, to be catheterized. Well, like, how are you going to do that if the house is under infection control? I don't know the answer to that, but I think it's a decision or a discussion that practices need to have around the country to sort of anticipate this is going to happen. So what are we going to do?
I have one more question for you then. So what's one takeaway you would want people to have from your book? I mean, it's so rich in all the information and the different best practices that are in there, but what's one takeaway you'd want from this conversation and if they were to go out and purchase the book?
I think do the best you can. You're giving the dying person a huge gift by doing this, and you're also giving a gift to the rest of your family who can see you do it. And it's not going to be perfect, and that's okay. Don't beat up on yourself. You're trying to do something that's extremely difficult, and that's a good thing to do. And be happy that you've been able to do that.
All right. Well, Dr. Sankar, thank you so much for joining us today.
Well, thank you for having us.
That is going to do it for this episode of Mindful Medicine. However, if you want to purchase Dying at Home, a family guide for caregiving, we're going to provide you with direct links to that in the episode show notes. And we'll also provide some excerpts and direct quotes from the book in those episode show notes. We're also going to put together an article on the MGMA.com website so you can read some of the best things from that book, some of the best takeaways from there. So until then, thank you all for being MGMA podcast listeners.